Hello and welcome back to the Planet Family Doc podcast. We are a production of the College of Family Physicians of Canada's Bezoar Centre for Global Family Medicine, and I'm Dr. Clayton Dick. I'm your host today and the medical education lead for the Bezoar Centre. For those who are new to Planet Family Doc, on this podcast we invite family docs, primary care providers, and their educators from around the world to share their innovative ideas, discuss how they find joy in their work, and discover trends that impact on family medicine at global and local levels. So, what defines a family physician? In Canada, we have 4 principles that help us define ourselves. And one of those principles is to be a resource to a defined practice population. And that means one has to be adaptable. One changes one's skill sets and the type of knowledge that one must apply in order to meet the needs of specific patients and specific communities. For some of us, that involves gradual change over time as our practice changes. For others, it may mean dramatic changes in terms of what we do based on where we live and who we are serving. And in this particular podcast, we're going to explore the journey of someone who has had to make dramatic changes as she's moved from country to country to country as part of our work. Our guest today is Sister Monique Bourget, or should we call her Dr. Sister Monique Bourget. She's a Canadian family physician and also a religious sister of the Order of Sainte Marceline. She's been a missionary for almost 30 years and has spent 25 years in Brazil doing clinical and administrative work and leadership. And for the past 4 years, she's been working in Benin doing similar kinds of work, but in very different contexts. In the first part of this episode, she's going to describe the formative experience that led to her to become a family physician, but also to take a spiritual pathway as a nun. She's also going to talk about the work that she did as a family physician and leader in Sao Paulo for over 25 years. And she's going to explore the value of team-based care in Brazil and how community engagement played a critical role in providing excellent health care in the communities she was working in. Let's join our conversation now. Hello, Sister Monique. How are you doing today?
Hello, Clayton. I'm doing very well.
Good. Could you tell us a bit about where you are, particularly for those who are unfamiliar with Benin, where exactly you are, and what sort of things you've been doing today?
Okay, so I live in Bourget, which is a city about an hour from Cotonou, which is the biggest city in Benin, which is in West Africa. And I've been doing a little bit of work as now in palliative care physician in a small hospital and also doing some pastoral work. But I actually live in a school because I'm part of a religious community. I'm also a sister. And so the school has 660 children.
Oh, wow. So it's pretty big.
Yes. We have from kindergarten until high school.
Oh, wow.
And it's always very lively. The children have a lot of energy and laugh and run. And it's a nice school because it's a little bit different from the villages. It has a lot of trees and it's nice to be in.
So that begs the question about what brought you joy today in your work?
I'm actually following now two patients in palliative care. And one of them actually calls me mom. She's 40 years old, but she has breast cancer. And her family doesn't very support her. Here in Benin, unfortunately, all the healthcare has to be paid. So it was nice when I came in her room today and she said, "Oh, there's my mom coming in." And that was just very heartwarming because it felt like you can really make the difference in somebody's life. So that was a very special moment.
I know that you're originally from Montreal, and as we know you, as you are a Canadian family physician, how did you end up becoming a family physician who's also a nun and who's also, by all accounts, a very deadly soccer player?
I think I've grown a little bit older. So I come from a practicing Catholic family, and throughout my high school, I was dedicated doing volunteer work, but there was this call in me to do something more. So I decided because here, well, in Quebec, we have what we call CEGEP, which is after high school, we have these 2 years, which are you have to sort of decide a little bit which branch you want to go into, pure sciences or health sciences. And so I decided to do between my two CEGEP year a volunteer activity. And I got the opportunity to go to Guatemala. And that was a very profound experience because I worked in a nutrition center with the religious community. And I saw the most malnourished kids I'd ever seen. And that was very striking for me. It was very difficult. But I think the most transforming experience was when I was visiting some families with some of the sisters. And the families are very poor. They were living into these bamboo houses and they didn't have anything. But still, they wanted for us to come in the house and they would give us a little bit of water. That was very hard for them to get water, but they would give us a little bit of water. And then when I came out of one of those houses, there was a little kid in the street and he was half naked. And he was looking at me and I was looking at him. And then the sister went off and we were there just looking at each other. And I really felt this call which for me comes from the Bible, which as Jesus says, I was naked and you gave me clothes. I was thirsty and you gave me water. I was hungry and you gave me food. I was alone and you visited me. So that was a big call for me. And that look of that kid just really transformed me. And then I said, well, I want to dedicate my life to others. So when I came back from that volunteer trip experience, I decided I wanted to go into religious life. And so I went through different congregations. I ended up coming back to the Sisters of St. Marcelin, which are the sisters where I studied for high school. And then came the time to go to university. And my family said, well, you should do something that could help others. And then my brother-in-law is a family physician and he's a great role model for me. So he said, well, going to medicine because medicine is going to open a lot of doors for you. And then, well, there's always applying to med school and being accepted. So I said, well, if it's God's way, I'm going to apply and then see if I'm accepted. That means I should go into medicine. Chose McGill because I got the opportunity to do pre-med. So I entered pre-med. 15 days later, I entered my religious community.
Oh, wow.
Yeah.
So everything all at once.
All at once. And then I actually, after my pre-med year, left for 2 years, did my religious studies in Italy because we were Italian-based congregation. And then came back and then did my med school for 4 years. And then chose family medicine because it was really the field where because I wanted to be an obstetrician. I really loved obstetrics. I like surgery too, but I also loved Emerge. And then, so I decided to do family medicine because it opened the doors to do a lot of things. And the congregation was already preparing me to go to Brazil because in Montreal, we only have schools and a house for elderly people, but there was no real field where I could actually practice. So during my med school, I had the opportunity to go to Brazil for a couple of rotations. And then I did my family medicine residency. I worked for 6 months to have a little bit of a hand and understand a little bit better the system in Canada. And then my congregation sent me to Brazil. And then I spent 25 years in Brazil, did a lot of things. And then after 25 years, the congregation decided, because we do vow of obedience. So the congregation decided that there was an opportunity in Benin to do a little bit more. And then, so here I am. It's been 3.5 years, almost 4 years that I've been in Benin. But it's very challenging, a lot more than I thought it would be.
That is quite the journey. I think that there's a lot of common experience that we in the global health slash family medicine community have, in the sense of having some kind of formative experience that guides us towards getting into this type of career. And there's always going to be a mentor who's a family physician somewhere that also inspires us. In your case, it's really remarkable because not only did you go through your medical education, but also your spiritual education at the same time. And then you end up in Brazil, and then you end up in Benin. It's really quite remarkable in terms of a life and career arc. Can we spend a little bit of time talking about your work in Brazil?
So I think as a Canadian, we have a great healthcare system. I think it was better when I did my medical school, and when I arrived in Brazil, Canada was very high as a model for healthcare systems. So the reception I got from physicians, from healthcare authorities was very good. People always wanted me to talk about Canada, talk about how the system worked. I really early when I arrived, I had also the great opportunity. Like I say, I was at the right time, at the right place, with the right people, and I was a family physician because Brazil in 1994, which is the year I arrived in Brazil, um, launched a program which was called the National Family Medicine Healthcare Strategy, right? Or PSF, Programa da Saúde da Família. I was living in the state of Sao Paulo, which is the richest state, and in the city of Sao Paulo, which is one of the biggest cities of Brazil, more than 11 million people. In the metropolitan area is 20 million people. And we were in the poor extreme west or east part of the city. And the Ministry of Health at that time said that he said, let's start in the big city of Sao Paulo, because if the program works in Sao Paulo, then it's going to work in the whole of Brazil. So that was a big responsibility. And because the sisters already had the partnership, like public-private partnership with the government sort of gave them the responsibility to start these family healthcare teams in the east part of the city. And because I was a family physician, although a young family physician with not that much experience, I was given the coordination of the implantation of the teams. So early on, I worked a little bit as a family physician there in one of the health posts. The health posts had pediatrician, internist, and gynecologist. So the figure of family physicians was not very present in Sao Paulo, although the specialty sort of had been developed in some universities, but it was very punctual, and because there was no field for them to work, the specialty didn't really evolve. So when the government started this national program, there's actually this possibility to have family physicians work in health posts. So we started 27 teams in 9 different units at the same time. So that was in 96. It was a real success from the beginning because the teams were put up, it was community based, and territory based. So every team was composed of 1 family physician, 5 healthcare agents, and each healthcare agent had to take care of about 100 to 200 families. So he would visit all the families, which would be all the families around his house and the streets that were close to him, so he could be going and visiting by foot. And then he would come to the healthcare to the team meetings, and we got really big changes in the indicators, health indicators for that population. So the government saw that it was a good program, that it could really help. So 6 months after, we were almost doubling the number of units and teams. And then it went on. After when I left Brazil, we had in our part of the city more than 250 teams. So, and it was covering almost a population of 900,000 people. It was a wonderful experience because to work with healthcare agents at the beginning, which were really people that were involved with their community to make changes, and that would really help to recognize the different families, work with many social problems as well, right? Because there's violence, there's work, and then there's many different things that were going on. And the nice thing is that the government didn't saw that working as a family physician in these areas, you needed a lot of other different things. So dental clinic were started, specialty clinics, and then mental health clinics. And so we a whole network of primary healthcare developed from that first experience. At the end, when I actually left Brazil, we were covering 2.5 million people with more than 100 healthcare posts with different modalities, and there was more than 12,000 employees. So it was a wonderful experience.
As you know, in Canada, there is a movement towards team-based care. And it seems to be that Brazil is ahead of the game, I think, compared to a number of Canadian contexts in the sense that they actually demonstrate true team-based care, not just sort of having a doctor and a nurse working together, but having a number of people who are working in the community, other allied health professionals, and a fairly sophisticated system of communication between those members of the team. And I'd wonder if you have one or two bits of advice or lessons learned from your experience in Brazil for those contexts in Canada that are wanting to move forward with developing team-based care in their communities.
Yeah, I think it's a wonderful program. I always tell people that Brazil, I think, has had a great intuition about organizing the system with the healthcare agents that are really important part of the team because they're part of the community. They're in the community. Maybe it's a little less in Canada. It's not as strong because people are a little bit more individualist and in their if you have let's say Montreal or the West Island. I'm from the West Island. I don't think the healthcare agent would have as such an impact because people don't know each other as much and they're not because of the climate as well and because of the way the houses are organized. But I think to have people to go and visit some of the houses would be very interesting.
Yeah, so I think that the role of community engagement and having the community almost having a representative who actually can make the community almost a part of the team, if you know what I mean. That sounds a bit like how they were approaching it there.
Right. He's the link. He's part of the community and he's also part of the healthcare team. So
Yeah.
he's the bridge between the two, and that's a wonderful. He can tell the healthcare team the opinions of the community, and then he can bring the language of the healthcare team in a more palatable way for the community to understand some of the aspects of the healthcare teams. But you're right in saying that. So that's I think one of the big aspects of the healthcare teams in Brazil. But the other point is the multidisciplinary teams that which is the other team-based aspect of what that Brazil I think really catched on the needs. So we have the dentists that are part of of the teams, and there are the physiotherapist, nutritionist, social worker, occupational therapist, psychologists, and these all sort of do some mentoring to the team. So you discuss if the family healthcare teams has some aspects of some patients they want to discuss, they call on the team and then they discuss together and they take some decisions together. And then they can refer to. So part of that team also has some consultations to do and visits to do. But there are some cases you need to discuss because the situation is so complex. So that's a very interesting model to have.
So what I'm kind of hearing is that it's not a particularly hierarchical team, that there seems to be a lot of respect between the team members. Everybody has their role and everybody listens to everybody else in terms of the care of the patients and the communities. Does that sound about right?
Yes, and I think the multi-professional aspect of the healthcare teams is also helped through residency programs. So now the residency programs are not only for physicians and nurses, but they're also for all the other multidisciplinary. So we would have a residency program in family healthcare strategy for pharmacists, occupational therapists, social worker, dentists. So they would spend 2 years training and receiving a small bursary for their training by the government specifically to develop this strategy. So I think that helps as well because they're all like at the same level, that they're all residents and they're all participating in the team. And then it gives them a better, not dignity, but self-confidence, right? They would have a better self-confidence for their work because they've also been trained as well. And they have this residency program and they have a graduation. So I think that really helps as well.
That describes a lot about the work you did in developing family med in Brazil. Was there anything else that you're particularly proud of in terms of the work that you did there?
Oh, I'd love to talk about my obstetrics experience because I think I was able to participate a little bit in humanizing the obstetrics when I actually went to Brazil the first time to do a little rotation. I went to see the obstetrics ward. I thought it was a horror movie because it's the hospital the sisters actually manage. And it was one of the only hospitals in the region that was having maternity wards. It was very populated and it was doing close to 1,000 births per month. So that means 30 per day. You can just imagine what I was taught in med school. And I had the great chance to go to La Salle Hospital, which had just been transformed into a lot of different labor, births, and postpartum rooms. So there was about like 20 rooms in the hospital to have births individually in the rooms. And when I got to Brazil, everybody would go through trichotomy. They would have an enema and they would have an episiotomy. That was the kit for every single woman. And almost all of them were actually induced. So it was women screaming, women with pain. There was no partners, nobody accompanying them. And then I thought to myself, and I told my congregation, if I wanted to change something in Brazil when I got there was really obstetrics. I said, no, this has to be different because it's one of the best moments for a woman, for a family to have the child coming in the family. And it has to be this horror movie with a lot of pain and a lot of isolation and solitude. And people would have these really condescending comments, and it was very, very bad. So when I actually went, I started to do some shifts. So I said, well, I have to try to understand and see how we can do differently. So I would go and stay with some of those women that I thought I could help a little bit. And I was a family physician, and there, family physicians don't do birth, don't do, don't help the women to give birth. It's only the obstetrician. So I said, okay, so how am I going to do this? But then I started, and I took some of those women that already had a child or two, and then I started to help them give birth, and I didn't do episiotomy, and it was going okay. And then some of the physicians started to look and try to understand. I had the midwives with me, and then we started to say, well, it can be different, and we don't have to induce everybody, and then we don't have to do trichotomy. And then one of the residents that was finishing that year sort of got interested in what I was doing, and then said, well, are you sure you're doing the right thing? That I said, well, why don't you go to Canada? Because I wasn't able to convince him that was really the way. He said, you have to see something else. You have to see how other people do. And he actually came, did a rotation, stayed for a month in Canada. And then when he got back, he was converted, and he said, oh, you're right. It can be different. And he was actually the son of the chief of obstetrics. So, yeah. So we together went on to this journey. So I became, in 1998, so 4 years after I had gone to Brazil, director of a smaller hospital, with a 250 bed hospital. And then it was a new hospital, so we could organize it and transform it. So we actually transformed the maternity ward and did some individual birthing rooms, so we could bring the family in and try not do the trichotomy, enema. And then we started this trend, and I really think we were one of the first hospitals to try to do something different. So I thought that was very a nice story to tell, because even though as I was family physician, because of the formation that I've had and all I think the fundamentation, the evidence-based medicine that we do in Canada, that was very, very important for me to be able to challenge a practice that had been done for many years in Brazil, and was able to, of course, with the people there, but was able to change a little bit some of the aspects of the maternity care.
And this concludes part 1 of our conversation with Sister Monique. In part 2, she'll describe the challenges she's been facing establishing family medicine in Benin, and the joys she has found in her work there. She also has a great story about soccer and has something very sisterly to bring for our potluck dinner. If you like what you've heard, additional materials and other episodes can be found at our Planet Family Doc homepage, which is planetfamilydoc.libsyn, spelled LIBSYN.com. We're also on Apple Podcasts or Spotify. We will be posting a new episode in this series every 2 weeks until June of 2024, so we invite you to subscribe. This is a production of the College of Family Physicians of Canada's Bezoar Centre for Global Family Medicine. I'm your host, Dr. Clayton Dick, and our producers are me and Rivka Chamali. Production assistance has been provided by Vera Showell. A shout out to the Bezoar Centre's podcast working group for their invaluable input. We value your feedback as well, and as if you would like to contact us, please reach us at bezourcentre@cfpc.ca. That's BESROURCENTRE@cfpc.ca. Thanks again for listening. We look forward to you joining us in part 2.